Hello and welcome. In the past, students have requested questions and answers on topics like antibiotics. This topic is sometimes hard to grasp by nursing students and advanced nursing students as well. Today I will present some antibiotics in a question and answer format, and I will begin with pneumonia. In the next few weeks, I will be doing a series of these videos. My focus will be on questions and answer format style, and they will be covering drugs that are commonly used to treat various illnesses. So stay tuned for that. Thank you. We're going to begin with question 1. These are all in multiple choice format. The most common bacterial pathogen found in community-acquired pneumonia is, answer is number 4. It's the Streptococcus pneumoniae. Okay. All of these choices, your H. influenzae, your Staphylococcus aureus, your Mycoplasma pneumoniae, and your Streptococcus pneumoniae, they will cause a person to have pneumonia. But the best answer is the Streptococcus pneumoniae. The predominant organism found in pneumonia depends on the age and health status of the patient. For all ages except neonates, Streptococcus pneumoniae is the organism most commonly found in pneumonia. S. pneumoniae is identified as the causative organism in 60% to 75% of adults with bacterial pneumonia based on sputum culture. Non-typable H. influenzae. What that non-typable means is that it's non-identifiable type of Haemophilus influenzae. And Moraxilla catarrhalis are common pathogens in patients with underlying lung disease. Staphylococcus aureus has been a common co-pathogen in influenza-associated pneumonia. Mycoplasma pneumoniae, a pathogen difficult to detect on gram stains or culture, is another common cause of pneumonia. Now that one actually, you can get mild infection and still, walk around and, feeling okay. It's also called walking pneumonia. Okay? So in many patients with viruses are the cause of pneumonia. Viruses are identified in 18% to 36% of pneumonia cases. Okay, we're going to move on to the next. First-line drug choice for a once healthy adult patient diagnosed with community-acquired pneumonia is, answer should be number 2, azithromycin. This is a macrolide. Okay. Initial empirical therapy for the previously healthy outpatient with no cardiopulmonary disease, no antibiotics used in the past 3 months. So they're kind of concerned about drug resistance S. pneumoniae infection. So they require that the person who has not used previous antibiotics and who does not have cardiopulmonary disease will be treated with an advanced generation macrolide such as azithromycin or clarithromycin. You would use doxycycline as a second choice if the patient is allergic or cannot tolerate azithromycin or clarithromycin. Okay. The newer macrolides such as azithromycin, that's a Z-Pak, have a lower incidence of gastrointestinal side effects and require fewer doses. So this improves the likelihood of patient compliance with therapy. So you can get the Azithromycin 500 milligram on day 1, followed by 250 milligram per day for days 2 to 5 is one choice, and the cost is about $25 per course of treatment with generic medication. Clarithromycin about 250 milligram to 500 milligram twice a day for 7 to 10 days. And that would cost the patient about $73 for about 10 days of treatment, either strength, whether it's the 250 or the 500 milligram. Then erythromycin, 500 milligram PO, QID for 7 to 10 days is the least expensive. It's about $17 for 7 days of treatment. So patient may be prescribed erythromycin 333 milligram TID, about $16 for 10 days, okay, or 500 milligram BID, and it costs about $15 for 10 days. So if patients have GI upset from the erythromycin at a dose of 500 milligram QID, they may respond to 250 milligram of erythromycin given QID. I know that erythromycin is not one of your choices here, but I'm just giving you some extra information. But we're going back to the question. It's going to be answer 2, azithromycin. Okay. The first line antibiotic choice for a patient who has pneumonia but has a history of comorbidities or are immunosuppressed. What would you prescribe on an outpatient basis? So you have your choices here. Your answer should be number 1, levofloxacin. Okay, levofloxacin is a fluoroquinolone. Presence of comorbidities such as chronic heart, lung, liver, or renal disease, diabetes mellitus, alcoholism, malignancies, immunosuppressant condition will require fluoroquinolone such as moxifloxacin, gemafloxacin, or levofloxacin. An alternative treatment in patients with comorbidities is a beta-lactam plus a macrolide, high-dose amoxicillin 1 gram, or Augmentin is the preferred choice. Patients with comorbidities cannot reliably take oral antibiotics to treat pneumonia. An appropriate initial treatment option would be, your answer should be number 2, IV or IM ceftriaxone. The other name for it is Rocephin. If the patient is over age 60 years or has comorbidities, is stable enough for home therapy, but oral intake is not assured, home parenteral therapy is an option. The drugs of choice for these patients are ceftriaxone, 1 gram daily via IV or IM, or levofloxacin, 500 milligram IV daily. Once clinical response is observed, the patient is switched to oral fluoroquinolones like levofloxacin. Although parenteral therapy is expensive, it is still much more cost-effective than a hospital stay. A 34 weeks pregnant patient has been diagnosed with pneumonia. She is stable enough to be treated as an outpatient. What would be an appropriate antibiotic to prescribe? You have your choices. Your answer should be 2, Zithromax or zithromycin is a macrolide. Pregnant women are at slightly higher risk for infections than other women because of diminished lymphocyte function and decreased functional residual capacity of the lung during pregnancy. Macrolides like erythromycin, azithromycin, and clarithromycin are safe during pregnancy, although erythromycin or azithromycin is the first choice, as each is pregnancy category B, as in boy, whereas clarithromycin is pregnancy category C, as in cat. Doxycycline, a tetracycline, is not used during pregnancy because it may cause discoloration of deciduous teeth in neonates. Fluoroquinolines are avoided during pregnancy due to concerns for fetal malformations based on animal studies. Women with comorbid conditions or recent antibiotics should be treated with a beta-lactam plus a macrolide. A patient asks you how long will it take to see an improvement after starting antibiotic treatment for pneumonia. And your answer should be 48 to 72 hours. Choice number 3. The patient needs to be monitored for response to empirical antibiotic therapy. The patient should become afebrile in 2 to 4 days. Leukocytosis most often resolves by the 4th day of treatment. Radiographic improvement usually requires more time and is not an indicator of improvement. If the chest X-ray worsens, yet the patient shows clinical improvement, that is the natural progression of the disease. If no improvement in clinical status occurs within 72 hours, the practitioner needs to consider that the pathogen is not being treated appropriately. 2 possibilities exist. One is that the antibiotic chosen is not treating the pathogen. Another consideration is that the pathogen is resistant to the antibiotic chosen. In an era of increasing antibiotic resistance, the practitioner is always choosing between the narrowest treatment spectrum and the shotgun approach to treatment. There are more powerful oral antibiotics available than those the American Thoracic Society recommends for empirical treatment. But if all practitioners routinely overprescribe them, then resistance will soon develop. Therefore, the prudent practice is to start with the recommendation and save the broad spectrum antibiotics for true cases of resistance. Along with prescribing antibiotics, adults with pneumonia should be instructed on lifestyle modifications to improve outcomes, including, your answer should be number 1, adequate fluid intake. Lifestyle modifications such as increased hydration, smoking cessation, and rest should all be discussed with patients. A 4-week-old infant has been diagnosed with Chlamydia Pneumonia. An appropriate treatment for pneumonia would be, the answer should be 3, erythromycin. And that's a macrolide. S. pneumoniae is the most common cause of bacterial pneumonia in children of all ages. S. pneumoniae is rarely found in neonates. So you would find perinatal infections from group B streptococci. That's found in the neonates, and it's the leading pathogen in this age group. Infants who are 2 to 19 weeks old and who present as afebrile with a repetitive staccato cough and tachypnea, cervical adenopathy, and rales are likely to have chlamydial pneumonia. Wheezing is rare. Chest x-ray will show hyperinflation and bilateral diffuse infiltrates. The patient may also have nasal stuffiness and otitis media. Diagnosis is confirmed by detecting chlamydia-specific immunoglobulin M in serum. The standard treatment for infants with confirmed chlamydial pneumonia is erythromycin, 50 milligram per kilogram daily for 14 days, or oral Zithromax, 20 milligram per kilogram per day for 3 days. These infants can usually be treated as outpatients if they are able to eat and maintain hydration. A 4-year-old patient who has suspected bacterial pneumonia has a temperature of 102 degrees Fahrenheit, oxygen saturation level of 95, and is taking fluids adequately. What would be the initial treatment for his pneumonia? Your answer should be ceftriaxone. Bacterial pneumonia in children usually occurs as a secondary infection following a viral infection. Primary bacterial pneumonia is less common. The viral infection affects the lung defenses, setting the stage for secondary bacterial infection. The pathogen that's identified is the S. pneumoniae. The prevalence of S. pneumoniae is decreasing, but it remains the leading cause of bacterial pneumonia in children, especially those that are under the age of 5. Now, so this patient is hospitalized, and the practitioner would choose to give IV or IM ceftriaxone 50 milligram per kilogram in one daily dose, or cefotaxime, which is a third generation cephalosporin, 150 milligram per kilogram per day every 8 hours. So those two drugs would be a good choice to use. If it was an outpatient, if you were treating it as an outpatient, the drug of choice for children under the age of 5 would be high-dose amoxicillin, 90 milligrams per kilogram daily, divided in 2 doses. Okay, and that's a drug of choice for 7 to 10 days on an outpatient basis. So this is just an extra information that I'm giving you, other than what you see on your multiple choice. Okay, so another extra information I would also give you is that although vancomycin has not shown to be as effective as the third generation cephalosporin with drug resistance Streptococcus pneumoniae, yet it is recommended if clinical, laboratory, or imaging characteristics are consistent with an infection caused by Staphylococcus aureus. So S. aureus, okay? So you would use, if it's an S. aureus, you would use vancomycin. A 14-year-old patient is presented to the clinic with symptoms consistent with Mycoplasma pneumonia. How would you treat this? You have your choices. Answer 2, azithromycin, that's a macrolide. Mycoplasma pneumonia is the most common type in children over age 5 years, with approximately 10% of school children presenting with symptoms consistent with atypical or mycoplasma infection. The disease is usually mild. The typical history includes upper respiratory symptoms, fever, dry cough, malaise, sore throat, headache, and possibly chills. Symptoms often last for 3 to 4 weeks. Chest X-ray reveals bronchovascular markings in areas of atelectasis. A polymerase chain reaction test for M. pneumoniae is the standard with 80 to 100% sensitivity and specificity. So the culture usually takes about 21 days to, I guess, get back the results. The treatment of choice for Mycoplasma pneumonia is a macrolide. The preferred oral treatment is Zithromax, 10 milligram per kilogram on day 1 and 5 milligram per kilogram on day 2 through 5. Though this is an alternative, you can use clarithromycin, 15 milligram per kilogram per day in 2 doses, or you can use erythromycin, 40 milligram to 50 milligram per kilogram daily, and it's given TID, QID, okay? And for larger children, 333 milligram PO TID for 10 days is another option. Erythromycin is inexpensive and provides good coverage for other atypical organisms. Zithromax, azithromycin, that's the other name, is also packaged in a Z-pack. So you have 5 days dose pack for older children or children over 50 kilogram. Printed on the package are instructions where they're supposed to take 2 of the 250 milligram capsules on day 1 and 1 capsule daily thereafter until it's gone. Because mycoplasmas lack a cell wall, they are inherently resistant to beta-lactam agents. So don't use that on patients. A 24-year-old woman comes to a clinic with complaints of dry cough, headache, fever, and malaise, which has lasted 3 to 4 days. She appears to have some respiratory difficulty, and chest examination reveals rales, but no other obvious signs of pulmonary involvement. However, extensive patchy infiltrates are seen on chest X-ray film. Gram stain of expectorated sputum fails to reveal any bacterial pathogens. The patient mentioned that a colleague at work had similar symptoms to those she is experiencing. The patient has no history of serious medical problems. She takes loratadine for allergies and supplementary iron tablets, and she drinks about 6 cups of caffeinated coffee per day. The physician makes an initial diagnosis of community-acquired pneumonia. If this patient was treated with erythromycin, what should she do? So your choices here. Your answer is C, decrease her intake of caffeinated beverages. The inhibition of liver cytochrome P450 by erythromycin has led to serious drug interactions. Although erythromycin does not inhibit loratadine metabolism, it does inhibit the cytochrome P1A2 form of cytochrome P450, which metabolizes methylxanthines. So consequently, you get the cardiac and you get some CNS toxicity could occur with excessive ingestion of caffeine. So unlike the tetracyclines, you don't get photosensitivity with erythromycin, nor are the iron pills affected by the erythromycin is not affected by the iron pills or the cations. Because erythromycin undergoes biliary excretion, the liver metabolizes most of the administered erythromycin. It undergoes demethylation through the cytochrome P450 system, specifically the enzyme cytochrome P3A4. It is then eliminated through bile. A very small percentage of the drug undergoes renal excretion. A 55-year-old male patient with no known drug allergies has been diagnosed with community-acquired pneumonia. The patient was recently treated with ceftriaxone for sinusitis. Which of the following information is relevant related to a risk for a drug-resistant Staphylococcus pneumoniae infection? And here are your choices. Your answer should be A, comorbidity with diabetes mellitus. Diabetes mellitus places this patient at increased risk for drug-resistant Staphylococcus pneumonia. Other risk factors for drug-resistant Staphylococcus pneumoniae, which is acronym D as in dog, RSP, DRSP. Other risk factors for DRSP include, but not limited to, patient age greater than 65 years and the use of an antimicrobial within the past 3 months. While smoking may contribute to risk, but there is no evidence related to exposure to secondhand smoke. The patient's age of 55 years and a history of antimicrobial therapy within the 4 months before do not increase the risk for DRSP. We are currently living through an antibiotic resistance crisis, mainly because antibiotics tend to lose their efficacy over time due to the emergence and dissemination of resistance among bacterial pathogens, principally caused by the overuse of inappropriate use of antibiotics. Populations that have been exposed to antimicrobials, especially within the past 3 months, are at risk of developing antibiotic resistance, and these patients are children younger than 2 years of age. Adults greater than 65 years are at the greatest risk for drug-resistant S. pneumonia. Besides diabetics, illnesses such as sickle cell disease, asthma, COPD, emphysema, alcoholism, smoker. We have the immunocompromised patients, those who have cancer, AIDS, HIV, damaged or absent spleen, patients with a cochlear implant or cerebrospinal leak. Cochlear implants or cerebrospinal leaks. Patients who have COPD, what vaccine or vaccines would you recommend in your plan of care? And your choices you have here, your answer should be answer B. Give pneumococcal vaccination with the Prevnar 13, followed by vaccination with Pneumovax in 1 year. Patients with COPD are at increased risk of contracting several vaccine-preventable illnesses. Patients who are older than 65 would have not received pneumococcal vaccine should receive vaccination with Prevnar 13. That's PCV13, followed by vaccination with Pneumovax in 1 year. Patients with COPD should also receive seasonal influenza vaccination using either trivalent or quadrivalent inactivated vaccine. Live attenuated influenza vaccine should be avoided in individuals with airway disease. A single dose of live attenuated zoster vaccine is recommended for individuals 60 years or older. If the COPD patient's pharmacotherapy induces low-level immunosuppression through the use of chronic to recurrent corticosteroids, Zostavax may still be administered as long as the corticosteroid dose do not surpass low-dose prednisone. That's less than 2 milligram per kilogram, and the max is like less than or equivalent to 20 milligram per day or equivalent usage. Some additional information that I'd like to give is several measures have been shown to reduce COPD exacerbation, including smoking cessation, pulmonary rehabilitation, proper use of medications, including metered dose inhaler techniques, and vaccination against seasonal influenza and pneumococcus.